It is truly an honor and a pleasure to be standing here today to share with you my reflections on the state of cardiovascular care and how the ACC is advancing the cause of heart health through exciting initiatives and wonderful collaborations. One of the highlights of this past year was to get to work with so many of you, leaders of healthcare organizations and cardiovascular professionals in the US and all over the world. This morning, I will highlight some of the exciting efforts and remaining challenges in achieving our collective goal of improving heart health. When we think about overall cardiovascular care, we need to consider all the elements. Certainly, first and foremost, the care of the patient with heart disease. But of course, there are many other factors that we must consider and dedicate efforts to, starting with early detection of disease, raising awareness about the impact of obesity, inculcating healthy behaviors, and considering the contributions of genetic factors, and importantly, ethnic backgrounds. In this overarching look at healthcare, let us reflect on Dr. Don Berwick's proposition regarding achieving the triple aim of healthcare. Aim for better care, better population health, and affordable care from the perspective of both the patient and society. So what is the role of ACC and other professional societies in realizing these goals? The ACC's answer to achieving the triple aim has emphasized quality, value, and professionalism. The college has also focused on patient-centered care and on seeking collaborations among organizations in the development of guidelines, quality tools, and health policy. Today, I would like to share with you progress on key ACC initiatives to help advance cardiovascular health. These include data registries and their impact, appropriate use of diagnostic modalities and interventions, strategies to empower patients with knowledge, and approaches to deal with public health challenges, both locally and globally. Now, national data registries provide important data on practice of medicine and patient outcomes. The National Cardiovascular Data Registry, or NCDR, celebrates this year its 15th year and has become really the flagship of registries, growing to a total of 7 registries. These cover most areas of cardiology, including interventional cardiology, ICD therapy, management of acute myocardial infarction, impact registry with congenital heart disease, as well as the Pinnacle registry, and most recently, the TVT registry. These continuously enrolling registries have grown tremendously in size and impact, currently with more than 24 million records. The Pinnacle registry, with 7 million records, is currently the largest outpatient cardiology registry in the country. What is also exciting is that NCDR has gone global, with presence in India, Brazil, the Middle East, among other countries. This enables sharing and comparing cardiovascular quality among and within nations worldwide with the goal of improving cardiovascular care. And we're so proud to collaborate with many organizations to enhance the value of these registries. For example, we work with the Society for Cardiovascular Angiography and Intervention on the CathPCI registry, with the American Heart Association for Action Get With the Guidelines, with the Heart Rhythm Society for the ICD registry. Our most recent partnership with the Society for Thoracic Surgery ushers really in a new paradigm. This TVT registry is the result of a new collaborative model among professional organizations, in this case ACC and STS, regulatory agency, the FDA, and the payer, in this case CMS, as well as the industry, to bring about an exciting, technically demanding, expensive new therapy that benefits patients with advanced aortic stenosis. This really ushers in a new technology in the future, a new paradigm to rolling out new technology in the future, mandating participating in registry for reimbursement while monitoring quality, patient outcome, and supporting research and innovation. The power of data reporting is really impressive and can change clinical practice and improve quality of care. Notice that in the door-to-balloon initiative for treatment of acute ST elevation infarction, and within just 5 years, the percent of patients achieving a time of less than 90 minutes improved from 45% to more than 90%. Now, before reporting of such data, most hospitals and physicians believe that they were doing a great job in acute MI care. We know that physicians and hospitals are data-driven, competitive, and are quite responsive to data reporting. In the same vein, a recent NCDR report on 500,000 percutaneous coronary interventions, the largest such report, also highlights the importance of registries. It is gratifying to see that PCI, where appropriate, in the overwhelming majority of patients with acute infarction, 98%, 98.6%, and certainly life-saving in many of these situations. In stable patients, however, the rate of inappropriate procedures was 11.6%. Those PCI were deemed inappropriate mostly because patients could have been treated medically and it could have been a patient preference. Most revealing from this study was the variation observed among hospitals in the rate of inappropriate PCI. The variation was significant and higher than one would have liked. This again points to the power of complete reporting and the ability to react to the data in the aim for quality improvement. It is also good to reflect on the application of knowledge. While science tells us what we can do, guidelines tell us what we should do, and registries show us what we are actually doing and will be doing in the future. For interventional cardiologists, I'm happy to report this morning that coming this spring, a physician-level dashboard will be available to you through the CAS PCI registry. This allows each one of you to monitor your own data, follow metrics such as captured volumes, vascular complications, door-to-balloon time, appropriateness, and allow you to compare them to national registries. You can use the information to improve the quality of care and also for maintenance of certification. The access is secure and confidential via CardioSource. The ACC is proud to enable such a resource, and I encourage you to take really full advantage of it. The college has been praised for the development of appropriate use criteria since 2005. These AUCs help clinicians as to when and how often to perform diagnostic testing or interventions. They now span all diagnostic modalities and more recently, therapeutic interventions and procedures. Just this past week, added ICD and resynchronization therapy for this growing list of helpful documents. I would like to acknowledge the many collaborating societies for their valuable input in developing these appropriateness use criteria and look forward to their continued support as we tackle other areas, such as multimodality imaging and heart failure. The impact of education and sharing information, just sharing information using appropriate use criteria, is illustrated in the Focus Imaging Program. This voluntary nationwide program of nuclear imaging has resulted in an improvement in appropriate indication for stress nuclear from 82 to 89% by decreasing use of inappropriate studies and those with uncertain indications. Combining appropriateness use criteria with recent outcomes research on imaging has without a doubt contributed to the observed trends of decrease in utilization of imaging in this country during the past decade. This is in contrast to the trends in the late 90s of exponential growth in imaging utilization. Going forward, partnering with the Choosing Wisely campaign from the ABIM Foundation to avoid unnecessary testing will likely strengthen and stabilize appropriate utilization of imaging. All the initiatives I just discussed are focused on improving the quality of healthcare. The commitment of the ACC and many other sister organizations to these initiatives is in concert with the report from the IOM on crossing the quality chasm. A key component of high-quality care places an emphasis on the patient, a focus dear to my heart, which has been the theme of my presidency. The ACC developed the CardioSmart initiative to improve patient-centered care. CardioSmart empowers patients and caregivers, encourages and rewards healthy behaviors, is likely to better outcomes, and supports the doctor-patient relationship. CardioSmart has evolved into an ecosystem that includes an enhanced website launched at this meeting, CardioSmart Clinical Community, free text messaging in English and in Spanish to alert patients to healthy behaviors and help them stop smoking, a toolkit, as well as the Heart Explorer to explain more easily medical conditions to patients. You will thoroughly enjoy the new CardioSmart website. It is interactive, organized by health conditions, provides information about healthy living, enables communities to connect with each other and share experiences, and provides the latest news, research, findings, and events. Importantly, there is an individual dashboard to allow patients to monitor their own activities, follow their health parameters, and connect with their healthcare team. The CardioSmart Explorer app is designed for tablets to help practitioners explain to patients how the heart functions and various cardiac conditions, such as a heart attack, heart failure, atrial fibrillation, and it also nicely illustrates various therapeutic procedures. A more informed patient is a more engaged patient and a more compliant patient, and certainly a healthier one. Now, beyond facilitating the engagement of patients in the clinic and between visits, CardioSmart is helping us get our message to the population at large. This is where we need to be, spreading the word about healthy living and healthy choices in the community. To this end, we have also partnered with an HLBI Heart Truth campaign and with the Spirit of the Heart initiative, the last event being just held yesterday here in San Francisco. Engaging in the community and advocating for health is one way to address public health challenges that we face in this country and beyond. And there are many challenges. Now, on one hand, looking back at the impact of cardiovascular interventions on outcomes, it is really gratifying to see the significant decline in cardiovascular mortality in the US over the past 40 years, thanks to advances in research, medications, devices, catheter-based, and surgical interventions. However, many challenges remain. In the US, many patients who need to take aspirin are not, and many are in need of better blood pressure control and cholesterol management. Smoking rates, although better than in other countries, are still far from optimal. These challenges provided the impetus for the Million Heart Initiative, whose goal is to prevent 1 million heart attacks and strokes in the next 5 years by addressing these so-called ABCs. The college and many organizations are collaborating enthusiastically with this initiative, headed by Dr. Janet Wright, an esteemed fellow of the college. Even more urgent, our challenges are looming globally. Death from cardiovascular disease exceeds any other disease and accounts for 33% of total death worldwide. It is higher than cancer, respiratory disease, and diabetes combined. These are the other main non-communicable diseases. The projected trends that you see here are really alarming, as they gradually increasing for both cardiovascular disease as well as cancer. Mortality rates for ischemic heart disease around the globe are high, the largest being in the Middle East, Eastern Europe, and Asia. Now, shown here are 10 highest risk factors for cause of death, total death, worldwide. The most important risk factors is high blood pressure, followed by tobacco use, high glucose, physical inactivity, overweight and obesity, and high cholesterol. Many of these risk factors are the same for other non-communicable diseases. Therefore, addressing them will have a major impact on global health and not only cardiovascular health. Prompted by the Non-Communicable Disease Alliance, the United Nations had its first ever high-level meeting on non-communicable disease in September 2011. What is unbelievable is that this was only the second UN Summit on Health after the AIDS Summit in 2001. The voice of combating cardiovascular disease was well represented by the ACC, the American Heart Association, and the World Heart Federation. The outcome of the summit was important. A political declaration that called on the World Health Organization to establish global targets for curbing non-communicable diseases. Indeed, the World Health Assembly met in Geneva in May 2012, so less than a year ago, and approved a monumental goal: a 25% reduction in premature mortality from non-communicable diseases by the year 2025. Last September, at the anniversary of the UN Summit meeting, the Global Task Force for Cardiovascular Disease sent a strong message: a health policy statement emphasizing a timely call to save preventable death from cardiovascular disease by addressing key risk factors. We were present at the World Health Organization Executive Board meeting in Geneva just this past January to advocate for the importance of targets for non-communicable diseases. Here you see Dr. Salim Youssef, Ralph Sacco, David Wood, and I at the World Health Organization headquarters. During the meeting, 26 nations took the floor to emphasize and to voice their support to these declarations. Now, to achieve the overall goal of 25% reduction in NCD mortality by 2025, the following targets were adopted: reductions in tobacco smoking, physical inactivity, excessive alcohol use, salt intake, raised blood pressure, diabetes, and obesity. Availability of essential medications to prevent heart attack and stroke were also emphasized. Going forward, there are challenges, but great opportunities to reach this ultimate goal, as risk factors are so prevalent and affordable, just traditional treatments no need for new inventions are so much needed globally. A big challenge is implementing the resolutions of various targets, knowing that these may vary by nation. There is hope that these targets will be included in the new Millennium Development Goals in 2015. It is really crucial to establish better funding for the NCD movement. Currently, non-communicable diseases cause 60% of global death and yet receive less than 3% of global funding. So the time is now for us to act. The time is now for us to work collaboratively. Ladies and gentlemen, cardiovascular disease is a global problem. We can protect population health by taking a global perspective, working together with ACC chapters and with national and international organizations. We can reach this noble goal. We're honored to work with dedicated colleagues and innovators throughout the world to bring about a vision of health and a commitment to one another and to our patients. Together, united, we will conquer cardiovascular disease. Thank you.